So good evening, everybody, or good morning or good afternoon, wherever you are. I know we have about 1,000 people registered for this webinar from 5 continents, except of Australia and Antarctica. And I know more and more people are joining now, but we have to stick to time. So I'm welcoming you to tonight's webinar on COVID-19, which is an update for obstetricians and gynecologists. I want to start by thanking our world-class speakers who have taken out of their time and to share with us their knowledge, their vast knowledge, and their excellent experience in the subject. And we want to thank them. And I'm going to present them to you one by one just now. I want also to thank Mina Farm, the leader, one of the big pharmaceutical companies in Egypt, for sponsoring this webinar. This webinar is a joint collaboration between the Egyptian Representative Committee of the Royal College, which consists of 4 fellows of the college and 4 members of the college, and I'm being honored to be the chair. Also in liaison with the ERC-RCOG liaison committee in the UK, which consists of UK consultants and professors who are friends of Egypt and who are helping us in these activities. They're chaired by Professor Mohammed Al-Fattah, who is a urogynecology professor in Aberdeen, and of course represented today by Dr. Hatem Musa, who is an associate professor in Leicester. Now, let me remind you of the situation now in our part of the world. This is the WHO situation report, which is issued every day. And this is the report of yesterday, the 14th of June. And as you can see, according to WHO, which gathers its information from the countries. Until yesterday, there were 7,690,000 cases, confirmed cases globally, of which 427 and 600 in the Eastern Mediterranean area, our area. There were, until yesterday, 758,000 cases and 16,640 deaths. And if we look at Egypt, yesterday, until yesterday, there were, until 43, we had 43,000 total cases with 1,677 new cases yesterday, with total deaths of 1,484. And these are the rest of the countries in the area, which is the EMRO region, the East Mediterranean Regional Office of WHO, and these are the rest of the countries. I know many of our attendees today come from many of these countries, the North Africa and the Eastern Mediterranean, the MENA region, Middle East and North Africa region. And this is this chart shows the situation, what is going on. As you can see, the red part represents Europe, and Europe is diminishing. The cases of Europe are diminishing, and they are on the slope is going down. On the contrary, the Americas, North America and South America, United States and Brazil is increasing, as well as our area of the world, the Eastern Mediterranean, as you can see, the dark violet, with also Southeast Asia is also increasing, with few cases in Western Pacific, and also Africa is apparently on the rising tide, beginning its tide. More importantly, Dr. Mahat Talat, who is an expert, WHO expert, who announced 5 days ago, that it seems that Egypt is expecting a second wave of coronavirus. And consequently, we are gathered today to discuss this in this webinar, and we would like to thank all the world experts who have joined us, as I said, and took out of their time to share with us their experience and their knowledge. Professor Christopher Lees is Professor of Obstetrics at Imperial College in London. He is the head of the Fetal Medicine and Queen Charlotte and Chelsea Hospital, and is a visiting professor at the Catholic University in Leuven in Belgium. I just want to continue, Professor Lees. I have 3 more.
I'm so sorry. So sorry. Let me go back into unshare the screen.
Can you stop sharing your screen?
Yes, I'm going to do that in just a moment.
Right. And
Sorry.
I will share my screen. No problem. So Professor Lees, as I said, is Professor of Obstetrics at the Imperial College, Head of Fetal Maternal Fetal Medicine at Queen Charlotte and Chelsea, and visiting professor in Leuven in Belgium. Professor Beverly Hunt is also joining us today, and we'd like to thank her very much. She's an officer of the British Empire, a fellow of the Royal College of Physicians, and a fellow of the Royal College of Pathologists. She's professor of thrombosis and hemostasis at King's College London, and a consultant at Guy's and St. Thomas's, and the medical director of thrombosis. And she's going to talk to us about thrombotic risk with COVID-19 and how to manage it. I'd like also to thank and welcome Dr. David Williams, who is a fellow of Royal College of Physicians and PhD, and the consultant obstetric physician at the University College London, at the Elizabeth Garrett Anderson Wing in London. The old people like myself remember the Elizabeth Garrett Anderson Hospital in the middle of Regent's Park in London, built by women, run by women for the sake of women, which has moved now to the University College in London. And we welcome Dr. David Williams. He's going to talk to us about the management of COVID-19 in pregnancy. And also we would like to, from beautiful Parma in Italy, in the beautiful Emilia-Romagna region, and the beautiful Parmesan cheese and the Parma ham, Professor Tiziana Frusca, professor and head of the Department of Obstetrics and Gynecology, the president of the Italian Society of Ultrasound in Obstetrics and Gynecology. She's going to talk to us about the organization of services and crisis management. In addition, we have another world-class expert, Professor Tom Boone, who is fellow of the Royal College of Obstetrics and Gynecology, and who also holds a PhD from the University of Gothenburg in Sweden. He's a consultant gynecologist at Queen Charlotte and Chelsea, and professor of practice in Imperial College London. He's very well known for his work, which gave him an honorary fellowship of the International Society of Obstetrics and Gynecology, as you know. More importantly, he may not know, he is an alumni of King's College Hospital, where I spent a good 5 years of my life when I did my PhD with Professor Stuart Campbell. I was in charge of the infertility clinic from 79 to 84 on the 4th floor of the infertility clinic, and the 5th floor of the IVF. And I think he came so we share a beautiful experience at this great hospital. With us today also is Dr. Tommy Musa. Dr. Musa is a very good friend of us, and he is always helping us with all our activities. He's an associate professor of maternal and fetal medicine at the University of Leicester in the United Kingdom, and he's also going to work with Professor Boone. And lastly but not leastly, I would like to welcome my colleague at the Egyptian Representative Committee, Dr. Wafa Benjamin, who is a member of the college, about to become a fellow. She's consultant in gynecology at Matarea Teaching Hospital, and she's going to help us, me and Tommy and Professor Musa, with the questions and answers. So please, if you want to have questions, please post your questions on the question and answer section, not on the chat section. And please mention your name and country if you like. And finally, I would like to thank again Mina Farm for their support of our activity. And with this, I would like to hand my microphone and my screen to Professor Bourne to present Professor Rees, and thank you very much for your attendance. Professor Bourne.
Thank you so much. Our next speaker is question. So I've come across yet in a webinar, so by your fervour. So yeah, well, just to echo Hassan's comments, welcome to this this webinar, which I think is going to be really, really interesting. Just to put things in context, sitting here in the UK, I think we now have 296 or 297,000 infections and 41,736 deaths associated with COVID-19, and that's probably an underestimate given how reporting has been going. I'm not sure if people think reporting is accurate in Egypt. That might be something we touch on later on. And I understand that numbers are, as we just heard, increasing in Egypt, so it's obviously becoming a major issue. But I'm delighted to introduce Christoph. Christoph, he's also went through the full King's College experience, I'll let you know, Hassan. So we all have the scars on our backs, or the pleasures, whichever way you want to look at it. It certainly was an experience, and one of the, certainly for ultrasound, it was a great place to learn, and it really was, the centre for ultrasound in its day. But Christoph now has moved on. He is head of fetal medicine at Imperial College. I think you've already been introduced, Christoph, so I'm not going to repeat all your many titles. But obviously, you're going to talk about something which is, I think, really important for everyone who's seeing patients with COVID-19, and certainly around the world caused a lot of anxiety about PPE, what to wear, what the evidence is to support the different types of PPE that might be used in different situations. And also the important point perhaps that, you have to worry about patients, but you also have to worry about your colleagues. One of the big things that we found is that people catch COVID from their colleagues if they're not very careful, something Tiziana, I think we talked about before when we had a webinar previously. So Christoph, I'm looking forward very much to your talk, and I gather that you've actually got examples of PPE. This is going to be like a sort of practical demonstration, so I'm really looking forward to seeing this, Christoph. Thanks very much. If you could unmute, Christoph. Well done.
Can you hear me now? Yeah.
Yes.
Is muting and unmuting me, so I think I'm unmuted. I was just saying, in the interest of decency, there's only a certain amount I will wear or take off in this presentation. So let's talk about personal protective equipment in obstetrics and gynecology. What are my credentials to give this talk? I've been interested in personal protective equipment for a while, and particularly in the context in the last 3 months of COVID-19. So I have, together with the International Society of Ultrasound in Obs and Gynae, ISWOG, got together expert groups who've been fantastically good and very learned in developing safety statements. So our first safety statement that is available free on the ISWOG website is the position statement on safe performance of obstetric and gynecological scans and equipment cleaning. So this is about how you disinfect rooms, keep machines clean and probes clean. But more appropriately for this lecture, I'm going to be talking about our second safety statement, which again is very freely available. All you need to do is type in ERC-RCOG PPE safety statement and you'll come to it. It's free. This was published, has just been published actually online, and was finished by us in April with an international group of experts. So it's quite a challenge getting together everyone to agree what the right level of PPE is in many different countries. And we learned an awful lot from experts in the Far East, for instance, China, Singapore, and Hong Kong. And I'll be touching on some of their suggestions and advice later on in my talk. So why PPE? Well, really three main reasons. Obviously to protect healthcare staff, but also to protect patients. And we often don't think about that so much. And thirdly, to maintain public confidence. If patients and doctors know that they're going to be safe in the hospital or in a clinic, then they're much more likely to come to it and be comfortable being treated there. So let's talk about the first part of that now, protecting healthcare staff. Why is this such an issue? Well, before COVID, the Far East, Hong Kong, Singapore, China, Korea, Taiwan had experience of SARS in 2003. So the SARS epidemic lasted from 2002 to 2004. And this is data from Sean Basu, who's Director of Public Health, Public Infectious Diseases in Singapore. So I'm grateful to him for this slide or these figures. In Singapore, there were 238 SARS cases that were confirmed and 33 deaths. So that's about a 14% death rate. Now, out of 238 that were positive in Singapore, 98 of them were healthcare professionals, which is an enormous number. Just under half were positive for SARS, and of those, 2% died. So relatively low death rate, lower death rate than in many other countries, but nevertheless very significant. And for just under half of healthcare staff to be affected is pretty scary. So fast forward to SARS-CoV-2, 2019 to 2020. In Singapore, 40,600 are positive for SARS-CoV-2 over the last few months. Number of deaths has been remarkably low overall, 26. And out of 40,000 positives, the number of healthcare professionals that are positive for SARS-CoV-2 is 66, and no deaths. So something has happened in the last 17 years to mean that Singapore, going from a risk of 42% of healthcare professionals being affected by SARS to 0.2 being affected by SARS-CoV-2. So an enormous change. Now, I'm sorry, I'm going to show you some tables just before we go on to the meat of the talk. In the UK, by the end of April, there are 119 healthcare professionals affected by SARS-CoV-2, that died from SARS-CoV-2. And these were split amongst nurses, midwives, healthcare support workers, doctors, dentists, other staff, including ambulance staff, porters, others. The median age was somewhere between early 50s and early 60s in all groups. There's a preponderance, particularly for males. Of course, you don't see that quite so much in particularly female-dominated professions and specialties. And what has been noted in the UK and the US is that Black and minority ethnic groups appear particularly susceptible to both catching the virus and mortality from the virus. So this is an interesting report that it may be interesting for you to read from the Health Service Journal just at the end of April, so 6 weeks ago. They haven't updated it since then. One really interesting thing to note is that the sort of doctors and nurses that you'd expect to be particularly affected are those working in intensive care units or anaesthetists, where aerosol generating procedures are carried out. But the odd thing is that these doctors and nurses were almost entirely absent from the mortality statistics, not necessarily from those that had caught the disease, from the mortality statistics. The reason for this is not known, says the Health Service Journal. These healthcare staff are rigorous about personal protective equipment and associated practices known to reduce risk. So it may be these doctors and nurses who gown up, don and doff, don in the morning, doff at lunchtime, don again in the afternoon, doff late afternoon, and are absolutely scrupulous about PPE. It may be telling us that PPE does actually work even in high-risk situations. So let's move from the UK to China. This is a very nice slide given to me by Jing Deng from China and working at UCL currently. If we look at the phases in China of SARS-CoV, and if we look at the infections in Wuhan initially, 2.2% of healthcare staff, 3,000 out of 136,000 were infected by SARS-CoV-2. There was virtually no PPE. There was insufficient PPE or it was depleted. In the central hospital, which was one of the hospitals that had most cases, they had 230 out of 4,300, so 5% got ill, and they had 5 deaths. In China, in Wuhan, the Chinese mounted a huge operation and brought in an enormous number of doctors and healthcare professionals from other parts of China. And the reported infection rate is 0%, so 0 out of 43,000. That is pretty impressive. I was slightly suspicious of a 0%, but let's take these figures at face value. The infection rate was very low. They were very, very well equipped from PPE point of view. In fact, they were wearing, in some cases, hazmat suits and positive pressure respiration equipment. So it just shows you something changed in that time, and it was PPE. So let's talk about something else, protecting patients. And I'm just going to show you a slide on this. There are many, many headlines on this, and a lot of interest on hospitals being the source of SARS-CoV-2. And this was, just a few weeks ago in The Guardian, up to 20% of hospital patients with COVID-19 caught it at the hospital. And this is because hospitals SARS-CoV-2 around on services, of course, and in clinic rooms, but it's also because of staff. There's poor social distancing. A lot of staff meet together and are frankly complacent about PPE. So, of course, when we're patient-facing, we've got to wear PPE and be careful. But when we're not patient-facing, we can't completely relax because we become vectors of the infection. So we've got to think about PPE and safety in front of patients, and also PPE in front of our friends and our colleagues in the hospital. Maintaining public confidence, well, it hasn't taken long for the public to realize that hospitals are very risky places, and doctors and nurses might well, and midwives might well carry the disease. So this is a problem because those with cancer diagnoses or concerned about their health just aren't coming to hospitals. Accident and emergency admissions have dropped by about 50% in many hospitals. So that's led to a major campaign by Public Health England and the NHS to say, look, please, if you suffer from symptoms and you would otherwise go to accident and emergency or go and see a GP, go and see them, because you're much more at risk of the underlying problem than in many cases than you are of COVID. So that takes us on to PPE, the evidence, because frankly, there isn't very much what we call high quality evidence. There are no randomized controlled trials. There are no randomized controlled trials of any size. There are small RCTs of using masks. And what I'd say is don't ignore the observational cohort data. We've got so many countries and so many healthcare systems that have done things in a slightly different way, depending on the imposition of public health measures and PPE, that we can start drawing inferences as to what works and what doesn't. I'm not going to go through this in any great detail, simply to say that public health interventions work. And if you can reduce the background rate of the virus, then of course you're much less likely to lead to hospitals becoming hotspots or healthcare workers becoming infected. So this is a wonderful paper from the BMJ just about 3 weeks ago, looking at the implementation of lockdown, the implementation of quarantining, the implementation of contact tracing. And I'm afraid the UK didn't do particularly well there. We didn't do well, neither did Spain, nor did Italy, and Belgium did very, very badly. The United States hasn't done quite as badly as we thought. They've got, of course, a 6 times larger population than the UK. So public health interventions do work. So if we're talking about PPE, let's just think about the things that reduce the need for PPE in the first place. And now let's talk about PPE itself. What do we mean by it? Well, we mean the things we wear, but also the things we do are very important. So physical distancing, certainly 1 meter or more distancing. And this is a systematic review among healthcare professionals and others. Distancing reduces dramatically the risk of infection. Face masks appear to reduce by about 6-fold the risk of infection. Eye protection by about 4-fold, 3 to 4-fold reduces the risk of infection. Again, this is very high quality data from the Lancet. Again, just I think last week, June the 1st, it was published 2 weeks ago. So the evidence for physical distancing, face masks and eye protection is pretty clear. And the really interesting thing is using all these 3 measures, implementing them at the same time, may have an even more dramatic effect, a cumulative effect on reducing transmission and infection rates. Now, I'm going to take you through 1 or 2 indigestible tables, but very, very good papers. And this is a paper from Tim Spector's group in the UK at King's, actually, risk of COVID among frontline healthcare workers and the general community. This is from an app called the Zoe app. And individuals registered their symptoms and what they did in terms of their work. And let's just look at general community versus frontline healthcare worker. There's a hazard ratio of about 11 times if you're a healthcare worker for being positive for COVID testing, and a hazard ratio of at least twice for getting COVID-19 infection. So there's absolutely no question that healthcare workers are at higher risk than the community. What about PPE in that context? Well, asking questions about PPE, the reuse of PPE and the availability of PPE, Tim Spector and his team found that reused or inadequate PPE very significantly increased by about 30 or 40% the risk of COVID-19 positive tests, the risk of infection. So this is really good, almost real-time information. What exactly do we mean by PPE? Well, there are different levels of PPE. So at a very basic level, we're talking about a surgical mask, a type 2R surgical mask, waterproof, which is what I'm wearing because I've been on the ward today. Then we move to FFP or N95 respirators. N95, that means that it filters out more than 5%, only 5% of particles less than 4 microns get through. An N99 respirator is even better. So this is an FFP3 mask, which you're maybe familiar with. FFP3 mask filters out 99% of particles less than 4 microns. A powered air purifier respirator, well, we don't really use those. These were used in the SARS epidemic, and I haven't seen anyone use these yet. So these are the general items. Now, goggles, of course, these are simple goggles that are very easily purchased, bought anywhere. Cycling goggles will do, or face visors, very important for operative procedures or clinic procedures. But don't forget, very simple things, gloves and spirit gel, because whenever you put masks on or off, whenever you do anything with your hands or wash your hands, that you should be squirting spirit gel and removing gloves and putting spirit gel back on. Now, I'm just going to show you a few slides before I finish on what the recommendations are. And I don't want you to memorize this because it's almost certainly not relevant to you. And it was relevant to the UK only in the early stages of the pandemic. It was when SARS-CoV-2 was not endemic. So we were asking people about travel history, occupation, contact with potential positive patients or clusters. So if they were negative for this, we had a much lower level of PPE. If they were TOC, what's called TOC positive, so they traveled to China or an endemic region, then a patient, if you were having contact with a patient, you would upgrade your level of PPE. And suspected, probable, confirmed cases, we would have upgraded PPE, so FFP3 masks instead of FFP2, instead of surgical masks, disposable gowns, goggles or face shield. And in the PPE ISWAG guideline, there's a very nice little infographic to guide you through what PPE you might use in this situation. But what I'd say is that this has become almost irrelevant in the UK because of the huge increase in cases. And I'm sure it'll be irrelevant now in Egypt. And you've got to take a common sense approach, which is that every patient is suspected of COVID. And that means that if you're doing ultrasounds, if you're in clinic, fluid-resistant plastic aprons, surgical masks, so a standard surgical mask, this sort of surgical mask type 2R, one layer of surgical gloves using gel before and after applying the gloves and taking them off. If you're in theatre or in a labour room, then we would recommend an FFP2, at least FFP2 respirators, and 2 layers of surgical gloves, and of course a full isolation gown and cap, eye shield and face visors, so that none of your skin is actually open to the risk of getting splashes on it. Now, third level is extremely rare. So aerosol generating procedures in obstetrics are rare, but in that case, we're talking about FFP3 mask, at least coverall, full face visors, and just that higher level of PPE. But really, it's degrees 1 and 2 that we're most commonly encountering in obstetrics and gynecology. So I think that's where I'm going to leave it. Sounds a little bit trite to say, but stay safe. Think about staying safe, because it's in our hands to keep ourselves and our families and our patients safe. Proper PPE with donning and doffing protocols saves illnesses and lives. I haven't gone into donning and doffing. There are lots of good videos on the web about how to put the PPE, the gowns, the visors, the masks on. If someone hasn't shown you, please look at those videos, because they are crucial to reducing the risk of transmission, particularly when taking the masks and the gowns off and gloves off, because it's very easy to accidentally de-sterilize yourself in doing that. I'm going to thank Jing Deng, Yeonapoon, Sean Vasu, and Tom, who have been with me. We've been with each other in all aspects of this journey over the last 3 months and developing guidelines that have become ubiquitous throughout the world. I will just say one more thing, and that is that it's also extremely important to register cases of COVID and what has happened with them. At Imperial, we're running the Pan-COVID registry, which you can very easily get to on the web, collecting data and outcomes on pregnant women who have SARS-CoV-2 or have COVID-19. And we've got something like 1,200 inclusions now. So we've got a very large number of cases, and we'd be delighted if any of those listening to my talk today would be interested in joining us. Just look up the web address, click on it, and you'll get all the information you need. I think I'll leave it there. Thank you very much.
Christoph, thanks very much. I think for many people listening, really, really important lecture. I mean, it's interesting, you mentioned the fact that you don't think there are many aerosol generating procedures associated with in obs and gynae, but I mean, there has been quite a lot of discussion about that and concern. For example, one of the questions we've had has been in relation to dealing with, what do you deal with at vaginal delivery, and particularly concerns because COVID has been identified in stool, gases, people panting. Are you quite clear that there's no question that this is an aerosol generating procedure?
Yes.
We also have laparoscopy as well, for example.
Yes. Very, very good points. I think there's been a real obsession on aerosol generating procedures, and I think that obsession has been ill-founded because in the early days of the discussions with Public Health England and trusts, it was very much suggested that high-level PPE was to be retained only for those procedures that led to aerosols, so intubation, bronchoscopy. But of course, that's completely nonsensical because most transmission of COVID is from droplets sitting next to someone, picking it up from the surface. So fortunately, that stance has changed, and a much more common sense approach, recognizing proximity to a patient. So if you do ultrasound, if I do ultrasound, I'm within 50 centimeters of a patient, I always wear a mask. And that is essential because you're not going to get aerosols from someone lying on an ultrasound couch, but you could very easily catch the virus. If we talk about labor, again, there was, in the early stages of the epidemic, there were all sorts of discussions about, does labor cause aerosols? Well, frankly, I don't care because someone's panting heavily, droplets are going into the atmosphere. They're sitting in a labor room probably for about 2 hours in the air. So midwives and doctors and to be properly protected in there, which is why the guidance in most countries has been for at least a surgical mask and preferably FFP2, FFP3 mask in anyone suspected or confirmed. You mentioned laparoscopy, and of course the Royal Colleges in the UK have taken a stance on that has changed and then changed again, but laparoscopy almost certainly leads to a plume of smoke and potentially virus as well.
I mean, one of the things that I suppose we haven't touched on really in this webinar is also testing, and this idea of which you mentioned about whether patients are at risk or not, and the limitations, which is if you look at the sort of symptom and tox screen, actually that was wrong for quite a long time because new symptoms have cropped up over time which appear to be more important. People have an obsession with temperature checks, which appears to be positive in about 15% of patients. Do you have anything to say about that and the performance of PCR swabs? Because I think the point you make, because we had a lot of discussions about the pointlessness, once you get to a relatively high prevalence, of actually screening people when the tests aren't very good and you have to make assumptions about how much COVID is around.
I think you've got to work out what phase of the epidemic you are in. And we had the absurd situation in the UK where we were asking people about travel history when actually most flights from China had been stopped. and it was clear that the virus was running rampant through the population. So in many countries now, I think you have to assume, unless you're in Hong Kong, probably, or Singapore, whereas with extremely low prevalence, but certainly Brazil, Eastern Mediterranean, US still, probably not so much European countries as it's going down. You have to assume, though, that anyone you come into contact with is suspected, and dress yourself in PPE accordingly. Now, as viral swabs as far as viral swabs are concerned, well, this is extremely interesting, because you are probably only positive detectable on nasopharyngeal swab in the first 3 or 4 days after seroconversion. So viral swabs have missed a lot of people, whereas symptoms that are now recognized to be very strongly associated with with COVID-19, such as anosmia and just reduced appetite and lassitude and myalgia, they have belatedly become part of the menu of conditions that are very strongly suggestive of COVID-19. Yeah. So we've learned, I just wish sometimes we could have phase shifted by 4 weeks and implemented what we know now to about 4 to 6 weeks ago.
Well, I think, unfortunately, quite a bit of it probably was known, but that's a whole other conversation. I'd recommend, if people are interested in the symptoms site, another person at King's, who Beverly I'm sure knows, Tim Spector. Anyway, so Tim Spector's work on this app, which people feed in data from about 4 million people, I think, now feeding in data about symptoms. So Spector T, if you look up the papers from that, tells you an awful lot about symptoms. I'm going to leave one more question, which I think is very relevant. Someone said, how do we protect our families? So, you know, you're going to leave now, you're wearing your hospital kit. What do you do? I mean, people who've got almost like a little anteroom, they take their clothes off, put them on the floor, leave their shoes outside. How do you protect? What's the best way to protect your families if you're working and you are at high risk? You've just told us the hazard ratio is 11.
So, well, certainly what I was doing and still doing to an extent is wearing only very easily machine washable clothes into work. Changing into scrubs.
I've never seen anything that isn't easily machine washable since I've known you.
Thank you very much. Thank you very much, Tom, for that.
Always a man for a cheap suit.
Yeah, a cheap suit in a tumble dryer, it doesn't work. But no, I've been wearing stuff that basically when I get home, it can be stuck in the washing machine. I wear scrubs during the day, and most of us with any patient contact now wear scrubs during the day. There was a real difficulty getting the right amount of scrubs. Scrubs, by the way, are the sort of clothes that we wear around hospital for patient contact. And now, thankfully, trusts in the UK are very well provisioned with scrubs. So I don't wear my outside clothes at work. I pick them up when I go home. So I'm going to go change and go home. Nevertheless, I'm still going to wear the stuff that I will bung in the washing machine and not wear around the house.
Okay, Christoph, we're going to have to finish there and say thank you for that tour de force of PPE. Thank you very much. I know we'll be coming back to you later, so I'm afraid you can't get out of your scrubs quite yet, I'm afraid. And we're going to move on to Beverly Hunt, Professor Hunt, who has already been introduced to all of you, so I don't have to rehearse where she's from and her background at King's in London. And I think, Beverly, I think we spoke on a webinar a few weeks ago, and thrombosis was on the up and becoming a big thing, and now I suspect you've got an issue because I think everyone's probably wanting to anticoagulate everything at the moment, but it's certainly become the big conversation about COVID, hasn't it? So we're very much looking forward to hearing you speak about thrombosis and thromboprophylaxis in relation to pregnancy. Beverly, thank you very much.
Thank you very much. So I'm here to talk to you about thrombosis and thromboprophylaxis. I'm going to take you on a journey, and we're going to talk about the hemostatic changes that we see with COVID and what's happening in the non-pregnancy area, and then the advice from the Royal College of Obstetricians, which, having read the guidance that is being used in Egypt, is at odds with what's happening there. And I'm really looking forward to the questions because I'm not sure we all agree. Okay, so just back to COVID, to remind you that the virus binds to the ACE2 receptor on pulmonary endothelium and epithelium. And for most people, thankfully, especially the younger ones, they're either asymptomatic or they have minor infection. And they might have things like anosmia or fever, and then they get better. The issue lies around those who don't get better. Somewhere between 5 to 10% of people will go on to get COVID pneumonia. And the problem with the pneumonia is that there is a massive inflammatory response. There's a cytokine storm with the lymphocytes and the macrophages that are invading, producing a lot of cytokines. And we end up with two groups of patients: those at moderate risk who have got hypoxia but don't need mechanical ventilation, and then severe who require mechanical ventilation. And all of this cytokine storm is leading to a profound prothrombotic state that we're going to explore. And for me, the other thing is, why are some people getting this prothrombotic state and the pneumonia? When you think about those at risk, so vascular disease, they've all got a slight inflammatory state which is there in the first place. And then the other thing to remind you about is that actually the coagulation system's an effector system of the immune response. So it's designed to wall off bacteria invading primitive organisms, and the fibrin will wall off the bacteria and stop the bacteria having effect on the rest of the organism. And then the other issue, which I think is so important in COVID, is when you get inflammation, if you really push the inflammation, you'll get thrombosis in the small vessels. And we see it in Behçet's disease and the vasculitides, and we treat those patients with anti-inflammatory. We don't give them anticoagulants. We give them anticoagulants, but we don't expect it to make a difference to the outcome. And then the last problem we've got is when you are hypoxic, as you can be with COVID, it makes the blood very sticky. It switches on all of the coagulation factors and tissue factor. So you, like us, we're all remitting patients outside of pregnancy anyway, because they're hypoxic. And this is our traffic lights at our hospital. The more hypoxic you are, the more likely you are to have more intervention. And then when we look at the histopathology of the lungs, right back to the beginning, which isn't so very long ago, but from Wuhan, we were finding that these patients have adult respiratory distress syndrome, and the hallmark of acute lung injury or adult respiratory distress syndrome is you see fibrin deposition outside in the alveolar spaces. And we also see this cytokine storm, and we know we've got high levels of ferritin, CRP, D-dimer, and fibrinogen. So if we go through every single case of histopathology, and there's quite a few now, they're all finding microvascular thrombosis in the lungs in areas of high inflammation. So for me, it doesn't mean that we've got a primary thrombotic problem. We have got thrombosis in the lungs because we've got inflammation there. And we call that change, and it's gradually being more accepted, immunothrombosis. So those poor little microvascular cells lined by endothelium, which has got a receptor for COVID. It's got the ACE2 receptor on it. It's probably expressing tissue factor, the passing through monocytes expressing tissue factor, the cells surrounding it expressing tissue factor, and so we get local thrombosis. So the other thing that we do see, and was described right from the beginning in all of the COVID patients who have severe COVID, is that they have high levels of D-dimers. D-dimers is a breakdown product of fibrin. But this actually isn't unique to COVID. So this is a nice study where the Wuhan doctors looked back at the non-COVID cases they'd seen the year before and showed they too, when they had pneumonia, had very high markers of D-dimer. So maybe it's something we've forgotten or we've never really looked at before. So why are the D-dimers raised, and why, as they were suspected to be by the Wuhan team, prognostic for outcome in those with severe COVID? They did a study and they showed the higher the levels, the worse the outcome. So they made the assumption that actually the breakdown of fibrin was all coming from activation of coagulation, and then which switches on. In fact, there are other causes of D-dimers to be raised. And so we go back to the acute lung injury, we get intra-alveolar fibrin deposition. And the problem with that is that gets remodeled and we get lung fibrosis later, but that's for later. But we know that actually the pneumocytes can produce urokinase, which is an activator of plasmin. And that if we look at SARS-infected mice, we find that the mice will increase the amount of urokinase depending on the dose of SARS they were infected with. So injured lung can produce D-dimer. So it may well be that why the D-dimers are so prognostic is actually the D-dimers are a measure of acute lung injury. And the other data comes from macrophages. Macrophages can generate plasmin and break down fibrin. And also they can do it by a unique mechanism. They can grab passing fibrinogen molecules or fibrin molecules, take them into the cell, into the lysosome, and then cathepsin D and degrade it and throw it out again. So moving on, we need to think about thromboprophylaxis. Let's look back at the literature at thromboprophylaxis in critical care, because this is where these patients are. And if we look back, there's a big systematic review of 7,000 patients showing that if you give standard thromboprophylaxis to patients who are in critical care, you've got a risk reduction of VTE by about 50%. And that low molecular weight heparin is actually better than unfractionated heparin in doing this. And it can do this without too much difference in bleeding risk. And so if we go and look at the Wuhan data, I don't know what you do in Egypt, but in London and the whole of the UK, we have to give thromboprophylaxis according to risk assessment. So anybody who comes in with COVID to critical care gets standard dose thromboprophylaxis. We've done that from the beginning. But looking at the Wuhan data, it looked like nobody got thromboprophylaxis at all. And then they started giving it to a group of patients, and they found that there was a reduction in mortality. Now, this paper came out very early, like many of the papers from early on, they're really poor. And we don't know what dose of heparin they were using, and we don't know why they gave the heparin to those patients, and whether this was properly randomized, but it does show there's a reduction in mortality in patients who have COVID, severe COVID. So now we've got a glut of literature from across Europe, and they're saying, hey, there's really high rates of VTE in patients in critical care. And if we look at the clock paper lower down, he looked at 184 ICU patients. They're still in ICU. They maybe been there a couple of weeks. They didn't give really good, very good thromboprophylaxis, but they said that 31% of the patients had some form of either DVT or an abnormality on CT pulmonary angiogram. Now, if you think about immunothrombosis, that will show up on a CT pulmonary angiogram. And how will it show up? It'll show up either as a segmental or a subsegmental opacity, lack of flow on the CT pulmonary angiogram. So if you take away those patients in that paper, you find that there's much fewer VTE. And perhaps if I take you to this paper here, this is from Saskia Middeldorp in Amsterdam. These are patients who'd been followed for a minimum of 5 days. So we're just catching them really, really early in critical care. They're taking nadroparin. They're getting a bigger dose if they are overweight. And when we look at what's happening there, they're saying that 11 had pulmonary emboli. But they don't perhaps have pulmonary emboli because they're all segmental or subsegmental. So they could be immunothrombosis. So I think one of the problems with the literature at the moment is that we are calling things that could be pulmonary emboli, but actually are immunothrombosis pulmonary emboli. So we've just been through our first 66 patients at St. Thomas's. They all got standard thromboprophylaxis. We discounted any segmental or subsegmental PE. All our DVT were line related. We had an overall rate of venous thromboembolism of 5%. And we had a bleeding rate of 6%. So where are we in what are we needing to do in thrombosis and thromboprophylaxis in COVID? Well, rate of venous thromboembolism in COVID patients. But is it actually higher than the current rates of VTE in critically ill patients who had pneumonia due to other things? We don't actually have that data. And I think we're counting the immunothrombosis as venous thromboembolism. We've got these two causes of changes on CTPA, immunothrombosis and a proper pulmonary embolism. And then we come to thromboprophylaxis. We use weight-adjusted thromboprophylaxis here. We would expect to see fairly high rates of venous thromboembolism in anyone in critical care because you can't stop them all. You're reducing risk by 50%. The questions are, would a higher dose of thromboprophylaxis be beneficial? We know if you give more, you're going to get bleeding problems. Should we use intermittent pneumatic compression? I think personally we should. And then we have the other issue of when they get home with their profound prothrombotic states, should we give extended thromboprophylaxis? And then we come lastly to what do we do with fresh pulmonary emboli, or we suspect them? Well, we can't use the D-dimer anymore to exclude because they're always very high, but that's always been a problem in pregnancy. So that's not new to obstetricians. We need to maintain high clinical suspicion and give them the appropriate amount of low molecular weight heparin. These are profoundly provoked events, and I would assume we'd only give 3 months thromboprophylaxis treatment. So the conclusions from outside obstetrics is we're getting acute lung injury in severe COVID. We've got that cytokine storm leading to inflammation and this prothrombotic state. And I think that the D-dimers are really measuring the amount of lung injury. They're coming from lung inflammation, not from clotting. What are the final rates of VTE? Because we measure hospital-associated VTE for inpatient stay and for 90 days after discharge. We haven't been following patients long enough to know that one. And then I have to challenge everybody. I have to say it seems absolutely illogical to give anticoagulation and expect the rate of immunothrombosis to fall. That is being driven, really driven by the inflammation, and we should be giving anti-inflammatory or antivirals right upstream in the pathogenesis. So then I come to the Royal College of Obstetrician Guidance, which I've been part of. And so we are asking women who are self-isolating at home and who are pregnant just to stay well hydrated and mobile through this period. If we have concerns, we do a VTE risk assessment according to the Royal College of Obstetrician Guidance. And we would consider infection with COVID as a transient risk factor. So they need to continue thromboprophylaxis if they're already on it. And if there are any other risk factors, we'd consider thromboprophylaxis and make sure that they had adequate supplies at home. And then if they've got ongoing morbidity and mortality, to talk to someone with expertise in VTE. And then, like non-pregnant people, all pregnant women admitted with confirmed COVID should get prophylactic low molecular weight heparin. And we'd stop at 12 hours before delivery. If they've got severe complications, I feel they should be treated in the same way as one would in a critical care patient. And different hospitals are doing different things, so it needs to be agreed between the obstetrician, the clinical care physician, and the hematologist. And then after discharge, if they've still got ongoing problems, if they've still got a pro-inflammatory state or they're poorly mobile, one would give extended thromboprophylaxis. And of course, if they're breastfeeding, we'd give low molecular weight heparin. And really, if they're very immobile, extend out for 6 weeks. So I've finished now, and I know that the national guidance and the hospital guidance in Egypt are very different from this, and that people are giving full dose low molecular weight heparin. I really would like to understand why. And I'm also worried about the bleed rate with full dose low molecular weight heparin in patients who are on the wards and may not be very well, but may still be mobile. Thank you very much for listening.
Beverly, thanks very much indeed. And it's really a story that's sort of unfolding, isn't it, this whole area. And clearly this issue of thromboprophylaxis, looking at some of the questions we had before your talk, because I know that Hassan's going to deal with a lot of the ones that are coming through. And you've kind of answered them, but just so that we've covered this, some people, there has been questions saying, you know, if women are on a prophylactic dose of thromboprophylaxis, should we give them a therapeutic dose? I know, I understand you've covered this, but I think we should just deal with it. If we suspect COVID-19, or carry on the same prophylactic dose?
There's no justification for giving full dose. Full dose low molecular weight heparin is a big step, and we have a definite bleeding rate associated with it. So there's no evidence to support that practice. So I would say no. No,
I mean, I'm listening to the main sort of real point you were trying to hammer home was really that one, I think, wasn't it? That
yes.
That's why I raised that question, just to give you the chance to do it again. And there's another question relating to the sort of interpretation of D-dimer levels. But, you know, again, as a guide to thromboprophylaxis, but I mean, in essence, you covered that very nicely, talking about that pulmonary damage, and that therefore it's not really suitable as any kind of guide, essentially, and that the level of pulmonary damage is probably why it has some prognostic capability in terms of the outcome. Is that fair?
Yes, that's comment? Very fair.
Yep. And so it kind of comes down to this, doesn't it? That 2 points, I guess. When clinicians are sitting there, and you know, how do they clinically discriminate between patients who have got a pulmonary embolus or immunothrombosis, when some of the conventional tests don't appear to guide them hugely? Because you're saying that previously lots of people on imaging are saying that these are PEs. How do they, or is it a reasonable assumption, given the data, that only 5% or so have a VTE, that probably what they're seeing is going to be immunothrombosis? It's
all about size. So the other thing is, if you've got a DVT in the leg, you're going to treat them for VTE anyway, aren't you? And if they've got clinical suspicion, they get suddenly hypoxic, then one would be clinically suspicious. I think it's really important. And when we started out with COVID, we had so many patients in the hospital. My hospital had 190 on ventilators in the first few weeks. We didn't have the capacity to go and do CTPAs on everybody. So if somebody went off and became a bit hypoxic, then we treated them for VTE. We assumed they'd had a pulmonary embolism. But looking back, probably some of them didn't have, and they just had the myocarditis that you see with COVID as well. And the echocardiogram isn't very helpful either, because if you've got right ventricular problems, that can be COVID on its own, not necessarily a pulmonary embolism. So I think it's very difficult. I'm not saying it's easy. I'm just saying that those small segmental, subsegmental things you are seeing on CTPA, the radiologist always writes, oh, here we are, we've got small pulmonary emboli. Let's think, let's remind ourselves, they are just obstructions in the flow in that vessel, and they could well be in situ thrombosis, immunothrombosis. And that's what we're seeing when we do post-mortems, an awful lot of thrombosis.
And now when you're going back through your data, the probability is it's not nearly as common having P as people thought in the past, I guess. I mean, the big thing then is therapeutic targets, and what, is there anything that rationally targets? I know a lot of discussion about dealing with the cytokine storm, anti-interleukin type drugs, and everything that seems to end in a nib, I think, is being tried at the moment, isn't it? Things like baricitinib and things like that for rheumatoid arthritis.
Well, you want anti-IL-6, anti-IL-1.
Yeah.
When you deal with thrombosis like that in COVID, it feels like you're dealing with a patient with Behçet's. I've got quite a few patients with Behçet's. It's common in Egypt. It's not much point giving anticoagulant. They carry on thrombosing on you. You need to manage the Behçet's with the appropriate anti-inflammatory. That's how it feels like with COVID. Very happy to be proved wrong one day, but I think if you get immunothrombosis, you should be thinking about anti-inflammatory treatment.
Is that too early because there's no trials though yet, presumably, or is that something where
people... At the moment, REMAP-CAP, which is a platform trial, it's a WHO platform trial, has got an anticoagulation arm to compare standard thromboprophylaxis, which you're meant to be giving critical care patients, with full dose anticoagulation. But they've been very slow to recruit. They only added this arm, and I think there are probably about 300 or 400 patients at the most that might have been put on it.
Beverly, you're going to get lots more questions at the end.
I welcome them.
I'm going to leave it at that for the moment. Thank you very much for that. And we are going to move on. Who is next? I've lost my bit of paper. I think it's David.
Yeah.
Sorry, my crib sheet disappeared out the window at the critical moment as ever. So Professor David Williams, again, we've, as everyone heard earlier, a consultant obstetric physician at the Institute for Women's Health in London. I suppose we slightly touched on your talk, so I apologise for that, David. We started talking about things in advance of your discussion about the management of COVID-19 in pregnancy. So looking forward to hearing what you say, and there's already questions coming through for you. So we'll have a chat afterwards.
Thank you very much, Tom, and good evening, everybody. So yes, I'm going to talk about the treatment of COVID-19 in pregnancy, and it was very good to hear Professor Hunt speaking about thromboprophylaxis, or the role of anticoagulants in the management of COVID-19, really as a prophylaxis, not a treatment. This being an infection primarily of the lungs, but with a very powerful immune element to it, which I will talk about now. So we see this progression of COVID-19 infections in pregnancy just as much as we do in non-pregnant women of the same age. And in fact, this radiological progression, which at day 11 of infection looks rather nasty, isn't generally as bad as it looks. So the lungs of infected patients tend to be more compliant than due to other infections. And I'll touch on how to manage that from a respiratory support point of view as the talk progresses. And as Beverly Hunt mentioned, this is a infection of two phases, really. So in most people, about 80% of all who get infected, the SARS virus gets into the alveoli and is dealt with by the local macrophages. If that's not sufficient to eradicate the infection, then there's activation of T cells and then the release of pro-inflammatory cytokines like IL-6, which sets up this severe inflammatory cytokine storm, and where there may be a role for anti-inflammatory medicines and indeed targeted monoclonal antibodies against IL-6, for example, tocilizumab. But that's not yet been put to any kind of randomized trial. Interestingly, unlike the H1N1 flu epidemic that hit us certainly in Britain about 10 years ago, pregnant women don't seem to be as adversely affected by COVID-19 as non-pregnant women, but they certainly get it, and there certainly have been deaths of pregnant women with COVID. And in fact, in the UK, the best audit of outcomes in pregnant women has been put together by the perinatal epidemiology group in Oxford, led by Marian Knight. And she published in the British Medical Journal a week or two ago, still in press, available online at that address there, 427 pregnant women, which meant that about 5 out of 1,000 maternities had been infected with COVID-19. And just like outside of pregnancy, it seems to be more common in women of Black, African, Asian, minority ethnicities, overweight, obese women, older mothers over 35, those with pre-existing comorbidities, in particular diabetes and hypertension. Most of them, 73%, gave birth at term, but 10% required respiratory support, and most of that was given by oxygen through nasal specs or oxygen masks. But some went on to require either CPAP, the continuous positive airways pressure, or ventilation. And 6 out of the 427 infants born to mothers with COVID were tested, and 6 of them were tested positive within 12 hours. It's unclear whether there is vertical transmission from pregnant mother to her neonate. It seems unlikely, but that it is more likely to be recent infection from skin-to-skin contact. The main presenting symptoms of women with COVID-19 in pregnancy are very similar to those who are not pregnant. So fever is the most common symptom, then cough, then breathlessness, fatigue and lethargy, so flu-like illness, going down to what you'd expect in a viral illness. But it's actually fever and breathlessness coming on at, or being persistent about a week into the illness that is most worrying, because these are women who are likely to go into that second phase of COVID-19, which leads to the cytokine storm, the immune thrombi and respiratory distress that we see also in men and non-pregnant women. So pitching up at 2 days of illness is not nearly as bad as pitching up at day 6 or 7 with those symptoms. That should set alarm bells ringing. So the important issues about the pathophysiology of COVID-19 infection have actually been learnt from 2002, 2003 with the first SARS COVID-1 infection, coronavirus 1, where we recognized that this virus with its spikes entered into the host through the ACE2 receptor, or using the ACE2 receptor, and also some proteases to facilitate entry into the host cell. And you see it here in a bigger close-up, how the spikes of the virus attach to the ACE2 and come in through endocytosis into the cell. And once into the cell, the RNA of the virus is released into the host cytoplasm and ribosomal machinery for multiplication through RNA-dependent RNA polymerases, more virus produced, and then reassembled back into a viral molecule before exocytosis out of the cell. And so there are various places here where there are opportunities for antivirals. Remdesivir is against the RNA-dependent RNA polymerases, and I'll mention how that's being used so far, mainly in non-pregnant women and men, to try and shorten the length of the illness. There's been some concern about the high use of ACE inhibitors and angiotensin II receptor blockers in infected people, especially out of those cases in Italy, where there seemed to be a concern that those who took ACE inhibitors and angiotensin II receptor blockers were particularly vulnerable to severe COVID infection. And what is known about sepsis and infection is that there is stimulation of the angiotensin 1 to angiotensin 2 pathway that leads to lung injury and vascular permeability and all the adverse effects of having a pneumonia, a viral pneumonia. You can see how ACE2, which is actually an enzyme, normally degrades angiotensin 2 and angiotensin 1 into vasodilatory angiotensin peptides that are benign and do not go down the angiotensin 2 pathway to cause the tissue damage associated with COVID-19. But it's some nice analysis of data put together in this paper of the New England Journal last month, which tells us a little bit about whether being on an ACE inhibitor or angiotensin II receptor blocker is harmful. And you can see with this forest plot, if you were receiving an ACE inhibitor, actually you were less likely to have a bad outcome, more likely to have a good outcome compared to those who were not taking ACE inhibitors. Angiotensin II receptor blockers crossed the unity line, and but edging towards being on a worse outcome. Those receiving statins seem to be better off than those who were not receiving statins with regards life or death in COVID. And this is men and non-pregnant women. Other interesting things, of course, that we know about, that being over 65, being a man, not such a good thing with regards to outcomes, having coronary disease, heart disease, chronic lung disease, and in this case being a smoker, although there's been some controversy about whether smoking, which actually interestingly has some acute anti-inflammatory effects, might be beneficial to those with COVID. The thing about pregnancy, if we tell women not to smoke, so and I would say to nobody to smoke to try and get better with COVID, but also we don't use ACE inhibitors or ARBs in pregnancy because they are teratogenic, in particular in the second and third trimesters. And similarly with statins, although there is increasing safety data about their use, but not a drug to start in someone with COVID, just on the strength of this evidence. There's this a trial in Oxford that is looking at different drugs that might improve pregnancy outcomes. And it's a very pragmatic trial that's sort of taking the best candidates as they come. So one has already been dismissed, much promoted in America, hydroxychloroquine, which has been shown to be not beneficial to people with COVID, and yet possibly not harmful either. There's been some retractions of two big studies, one in the New England Journal and one in the Lancet, about whether hydroxychloroquine actually did more harm. It certainly does no good and is not a drug that should be used in COVID. Of interest is the tocilizumab, which is the anti-IL-6 monoclonal that might be of benefit in the second half of this illness. But nothing has yet been shown to be of benefit in a randomized controlled trial. Well, with one little exception, and it wasn't a randomized controlled trial, but published just a few days ago actually, was remdesivir, which is an antiviral used to treat Ebola and now used in those with severe COVID-19. And that there is no controlled data on this. It looked at generally older patients who were critically ill with COVID, and then appears to be some shortening in the length of their illness for those who had remdesivir compared to a general group who didn't receive it. This looks like the most promising drug for the treatment of severe COVID at the moment. There's a lot of interest in convalescent plasma, that is plasma taken from people who have recovered more than 28 days from a COVID infection and who have the antibodies against the coronavirus. And that is being collected to be given to the critically ill. And only observational studies have been done to date, which have seen people who've received convalescent plasma improve, but of course they may have done anyway. So the benefits of that, which were quite promising with SARS-1 actually, but yet to be proven in this COVID-19 infection. I think a very important points about the management of pregnant women with COVID-19 are identifying those that are at risk of going into the second phase, hyperinflammatory second phase. And as I mentioned, it's the late presentation, so they've already been ill, symptomatic for 5 or 6 days, and then they're still pyrexial, still breathless, minimal exertion. Oxygen saturations less than 94% would be a big worry. They tend to be lymphopenic as well, with a low potassium, which actually may interestingly be a consequence of stimulation of the renin-angiotensin 2 receptor, leading to potassium out and sodium in. But so unchecked COVID infection, of course, a high C-reactive protein, and then those other inflammatory markers, D-dimer, ferritin, that we've heard about. So the acute management of COVID-19, in the absence of any clear benefit from an antiviral or anti-inflammatory, are supportive measures. And that's escalating levels of oxygen through nasal specs, if that can't deliver enough to keep the maternal oxygen saturations up, through a mask. And then at my hospital, we use a lot of CPAP, the continuous airways pressure, either through a box or through a mask, positive airways pressure. And it does seem to keep a lot of people off ventilation. And when you do over-ventilate, and I think there was a lot of lessons learned out of the Italian experience, there's a lot of barotrauma and irreparable lung damage as a consequence of that. So we try hard to avoid ventilation, but of course sometimes it's necessary. If you need ventilation, outcomes are generally not good. Keeping well hydrated is important. There's a lot of acute kidney injury associated with this condition, and they turn up very dehydrated, so need fluid, thromboprophylaxis like we heard, but not treatment, therapeutic, antibiotics to keep away secondary infections, possible entry into the recovery trial, which is, I'm not sure if it's going internationally in Egypt, but we certainly put pregnant women into the trial here. And then the interesting consideration of early childbirth, especially if the mother needs ventilation, because there is a lot of benefit from being ventilated in the prone position, where blood flow to lung tissue at the back of the lungs is free to be aerated. That's difficult when you've got a gravid uterus, but being nursed on the side, it makes it possible. interestingly, unlike H1N1, where early childbirth and then ventilation seem to improve outcomes, that doesn't seem to be the case with COVID-19. And so keeping pregnant, especially if it's before 30 weeks, is something that we're trying to do in our network, and then the mother recovers and the pregnancy continues. The search goes on for a vaccine, and one is being trialed here in the UK, but it's going to be a while before it comes, and it's a really hard thing to test for when we've got, at least in our country, a declining amount of COVID infections. Maybe we need to enroll Egyptians into the trial, and I know, in fact, they've gone to Brazil to try and recruit more people for vaccine trials. So on that note, I will stop talking and happy to take questions. Thank you.
What's happening? Oh, your screen's still going. David, thanks so much for that. Just asking some straightforward questions from the audience. Is there any role for, or maybe that perhaps this is more about the preventative stuff that I think people are taking at home? People have talked about zinc and vitamin C. I mean, there was a vitamin C trial in China, wasn't there? I think it was a very high dose vitamin C. But are any of these things, lactoferrin, there's this chap, I think someone here has just asked, any comments on that at all?
Yes, nothing works. So it's all myth and sadly at the moment ineffective. So don't. You know, there's a lot of these things are pushed with great enthusiasm, but really they lack the evidence to of benefit.
Because there was the whole vitamin C D story, wasn't there, as well? And
I mean, you know, we need to be as fit as possible, slim, fit, to take on this infection. And being well dosed up in vitamin D is not a bad thing, but you know, not specifically against COVID.
Okay, and one person wanted to ask about, which I think I know what your answer will be, but I'm going to ask it anyway, and that was about hydroxychloroquine. Apparently this has been put forward as prophylaxis for medical staff. But I just think, just to cover this, could you make a comment on that, do you think? Yeah,
well, it doesn't help prevent or treat COVID-19. And the concerns that it might be harmful are probably over-egged, and the data that comes from has been put into doubt, so it has been retracted.
Yes.
We use a lot of it in pregnancy and outside of pregnancy, and it's generally a well-tolerated drug, but it doesn't seem to have a place against COVID, prevention or cure.
Okay. I mean, we did touch when I was talking to Beverly about these sort of more anti-inflammatory type drugs and you know, anti-IL-6, things like that. I mean, and I felt I'd rather touched on your area. So do you have any kind of thoughts on that? And I know that some of the sort of rheumatology type drugs are being repurposed, and I guess you know, in a compassionate fashion, are people sometimes giving this within, or is it only within trials? What's
Well, it's a bit like remdesivir, which was on compassionate grounds. But you know, these sorts of compassionate uses don't really help us. You know, we do need to balance it up against a placebo or something else. You know, the clinical phenotype of COVID-19 is relatively broad, but once you get onto a ventilator in an ITU, your outcomes are poor. And that's where the expensive targeted monoclonal antibodies would possibly be of benefit to stop that driver to immune thromboembolism.
I mean, I suppose for me, and I'm no expert, but I mean, I always look at lots of trials, and I don't know if Beverly might have a comment if she wants to unmute, but it's this issue of where in a disease course you make your intervention. And of course, you know, we see this in oncology trials where you know, people introduce some drug, but it's always people who've tried everything under the sun. They've got, you know, by the time they get this drug, there's a problem. And perhaps, you know, and I feel perhaps, you know, you need something in this disease to be giving people early on, which prevents this whole thing kicking off. So, you know, you end up probably giving one of these drugs in sick people in hospital, when the right time to give it would be to do a randomized trial for people on day 3, 4, 5 to stop them getting to the point where they go off on day 10. I just wonder whether both you or Beverly have a comment on that about timing of intervention.
Yeah.
Well, stupid gynecologist.
It's no, it's a very valid point. The downside to that is that 80% or more of people, and probably 90% of women who are pregnant because they're young and female, have a mild disease and don't need treatment. They'll get over it quickly, and most of them asymptomatic. So, but you're right. If you wanted to stop the pathway, you need to go in early. Once it's triggered, it's really, you're on the back foot, and it becomes a bit desperate.
Running away from you. Beverly, do you have a comment on that at all?
Well, obviously, we'd much rather have a vaccine, but if we have got virus, then we want something to reduce viral load early. We're going to hopefully do a trial of nebulized heparin, because heparin stops the binding of COVID to the ACE2 receptor, and antivirals early on would be really exciting to use. I mean, we really don't want to get the body to the state it is in severe COVID infection. I think that's a really important thing to think about. And actually, we need bigger and more effective models of predicting who's going to get severe COVID. Because unfortunately, although it is, we can say, oh, it's mainly old and obese and diabetic, there are a few people who don't fulfill all the criteria, and that's an issue too. So we need to learn a lot more about the disease.
I mean, I think the other problem, of course, is what's becoming clear is the longer term impacts of having these inflammatory processes go on. And it's manifesting itself in, you know, every week you see another, you know, whether it's COVID toe or COVID rash or COVID, you know, post-viral disease or even neurological problems. I think it perhaps isn't quite as benign in some people who don't get that sick as people maybe think it is, because it has quite an impact on quality of life, I think, for quite a lot of people. I think we'll find this happens. The tail of COVID, you know, these long tail COVID becomes a big issue.
Absolutely. The sequelae to the heart and a sort of cardiomyopathy and related to microvascular ischemia and to the brain. So at our neurology hospital close to us, they're seeing really odd neurological sequelae to COVID, and the cardiologists are reporting extremely odd, never seen before cardiomyopathy type issues. So you're absolutely right. This is the beginning of it. You know, it's there's a lot we're going to learn about the consequences of it.
Okay, well, listen, thanks both of you for that. We'll come back to you. David, many thanks. I'm going to move on, if that's okay with you, to Tiziana Frusca, who, as we've heard already, is Professor and Head of Department at the University of Parma. Now, Tiziana is going to talk about something which is really important, which is this issue of how do you know, what do you do when all this hits you? How do you organise your service, and how do you kind of, if you like, manage the crisis? So Tiziana, really looking forward to hearing what you certainly were very early, and we've all, having watched you, kind of suffered the same fate, as it were. So I'm sure we'll learn a lot from you. Over to you.
Thank you so much for inviting me to share some idea about how we organized our unit during the emergency, the COVID emergency. As you can see here, this is Italy. The most affected region were Lombardy and Emilia-Romagna, and Parma is here. And I want to share with you how the spread of infection was fast. As you can see here, we had the first 16 cases in Lombardy on February 21st. And in two weeks, on March 8th, there were 16 million people who were put on red zone, which means there was an administrative order called Io Resto a Casa, which means stay home, and it was extended to all Italy. This is how the spread of infection put the government to decide this very strong measurement. Just at before the lockdown, just when the first cases were detected in Lombardy, we started to put on some organizing changes in order to reduce the spread of infection. And this was done by very simple measures, such as reorganize the seats in order to leave at least 1 meter between two seats, as you can see by the slide. There was a checkpoint at the entrance of the building where there was a triage for all the people entering, either doctors or visitors. The staff was invited to wear the surgical masks at the beginning, and anyone who entered the unit was invited to wear surgical masks. As for university activities, we start on February, on the last days of February, to organize web lessons, web examination, web thesis, no conferences, no masterclass, no students or training doctors in the unit. And all staff was invited to wear surgical masks, and even all women, even not symptomatic women in labor and delivery, were invited to wear surgical masks. And although this was something that at the beginning was very, very controversial, we gave to the midwives the rule of using the N95 mask and the face shield during labor and delivery. And after a few weeks, it came out that this was the right things to do. So we were very, very keen on that. And we had to organize a COVID dedicated area. We also need, as there were so many emergencies and so many patients in the hospital for the COVID infection, we needed to free anesthesiologists for intensive care unit and to free medical doctors to go to help in COVID unit. So all the gynecology elective, not oncological surgery was cancelled. So this means that in our unit we had 8 surgery sessions a week, and there were only 3. And all specialists, even gynecological specialists not attending labor and delivery and not attending maternal fetal medicine, were shifted to emergency and to COVID units. So many of my colleagues went to work in the COVID unit. As for the appointments, the clinical appointments, all the appointments were rescheduled in order to avoid patient crowding in the waiting room. And this was particularly important as, for instance, we changed it. We canceled all the ultrasound and clinical evaluation for gynecological problems not considered urgent. And also the assisted reproductive program was suspended, temporarily suspended. All clinical evaluation for obstetric patients were guaranteed, such as booking for labor, for elective cesarean section, evaluation of anesthesiologists for epidural, high-risk pregnancies. All appointments for ultrasound and prenatal diagnosis were reorganized, but we guaranteed to all pregnant women nuchal translucency, prenatal diagnosis, high-risk pregnancies, and it was set up a room for ultrasound and clinical evaluation in patients who were known to be positive with proper protective device, as Chris Lees showed in the first presentation. Then we had to organize an obstetrics COVID unit. Unfortunately, my building, the building where our unit is a very, very old building. So we had to change the space, and what was previously occupied by the day hospital. The day hospital was closed, and a labor and delivery and cesarean section room was organized for COVID patients. In that room, of course, we had a CTG, ultrasound machine, and even 3 beds for patient after delivery. And midwife were when they had to assist delivery in a COVID positive patient, of course they did wear very high level protective device. We had a protocol for evaluation of all patients with symptoms or suspected cases. These patients were seen in an isolated room, patient attending to the emergency, and there was a triage based on the oxygen saturation and respiratory rate. Patients with low oxygen saturation below 95 and respiratory rate in a high respiratory rate were sent for a CT scan. We didn't use the RX or we didn't use the ultrasound. We just sent patient to CT scan. And when the pregnant patient was COVID positive with pneumonia, these patients, if she had no urgent obstetrical problems, these patients were sent to the medical COVID unit, which is a building nearby our building, where we had 24-hour consultation from a maternal fetal medicine specialist. So cases where they had pneumonia were not in our obstetrical unit, but in the medical unit. This is with the results of these 2 months. It was from the 15th of March to 15th of May. In 2 months, we had 13 pregnancies, but as you can see, only few of them had pneumonia. Most of them had had not important symptoms. And we had 4 vaginal delivery and 2 cesarean section for obstetrical indications, not for severe pneumonia. So the incidence was 5 over 1,000 maternities. And very recently, just a few days ago, was published this paper about the population-based study in Italy from 25 of February to 22 of April. We had 335 patients pregnant with COVID, with the rate of 2.1 for 1,000 maternities at the national level. But as you can see, in Lombardy, the rate was higher, was 6.9 per 1,000. In our unit was 5 per 1,000 in maternities, 5 for 1,000 maternities. These are the results of the national population-based core studies, where you see that the severe morbidity was only in 4.8% of cases. We had no maternal death, and only 2 cases had orotracheal intubation. Professor Williams already showed this slide. It's interesting because you can compare the incidence of the COVID pregnancies, and you see it's almost 5 per 1,000 maternities in UK. This is the paper on the British Medical Journal published few weeks ago. And in that, in this experience, the critical care, the need for critical care was in 10% of cases, and they had 5 cases, 5 patients who died. The positive newborns were 6 cases at less than 12 hours of age, and another 6 cases at more than 2 hours of age. At the moment, there is no reason to think that we had a vertical transmission. Most probably, they are related to skin in after delivery. In our cases, in our 4 cases who delivered, we didn't allow skin to skin, and we didn't allow even the baby to stay in the same room because our room is very small, and the woman was was giving milk through nipple stimulation. Now this is how is COVID problem in Italy. It's updated to last week. As you can see, and I think it's very important to realize that more than 28,000 healthcare workers were infected, and more than 65 cases of healthcare workers died. So one of the big problems that we have is really to protect the staff. And this is how the things are changed in Italy. As you can see, this was the peak. It was about at the end of March, and this is how it is going down. This is updated to the 3rd of June. And generally, you know, we had this lockdown, general lockdown with no school, only hospital and food and drug store open, no university. Almost all the beds of the hospital were converted to COVID emergency, and all the people who's locked in the house. And this lasted from 8 March till 4 May. So 2 months of people locked in house. This phase 2, who started on the 4th of May, it's the phase where we started screening with swabs for all patients that were entering the hospital for elective surgery or in labor. Because nowadays the problem is to detect the asymptomatic patients, which probably is the reason why we will probably have another spread of infection, maybe in a few months, we don't know, but we have to be prepared to that. And in this phase 2, there was a gradual opening of industries and activities. Now we are in phase 3. This means that starting from the 3rd of June, we could travel among Italian regions because they were open. And starting from today, we can travel through Europe, but of course not outside Europe. So I think it was very important, this general lockdown, in order to reduce the infection. And what I can tell is that it was very important to take very careful organization changes in the beginning of the infection. I remember when we put this staff in the front of the hospital, that was the staff was checking everyone who went to the hospital. We were criticized for that because it was a bit strong as a decision. So what are my take-home messages for? I mean, it's very simple, but I think that one of the problem that we had in Lombardy, it was that the government of the region didn't make many swabs. So one of the region which was going better than the Lombardy was Veneto, the region where Venice is, because they had the policy where they did a lot of swabs. So I think that in early stage of the epidemic like the COVID-19, we should make as many swabs as is possible in order to detect and isolate asymptomatic patients. And nowadays there is a big discussion, political discussion about the policy that has been used by Lombardy, which was really very fast infection rate and not so good in isolating the patients. We need to be prepared. You need to be prepared to an exponential increase of infection and start immediately wearing personal protective devices. Another thing I would say that I had to reorganize many times my unit because things were going to change. So we had to really rapidly many times change the program of the organization and on the schedule. We also had to cover to take the patient that were, because there were 2 hospitals nearby us that were closed for the COVID. So all the pregnant patients of these hospitals had to be taken by us. This was a very big, really very big work for us. And the other thing I think it is very important, I learned from this emergency, was the need of the empowerment of the staff, because it's really very important. I remember when I told to the midwife, okay, you are in labor, we don't know what is right, but anyway, you should wear FP2 and the face shield. They were happy. They were feeling that someone was thinking to them and was giving them protection. So this was very important, because they felt they were supported. So this is what I can suggest you. So I am happy to answer your question if you have any question. Thank you.
Tiziana, thank you very much for that. There's an awful lot there really in terms of things to learn, but I think the final point you made about supporting staff and staff well-being and making staff feel supported is extremely important. And I think I'm not sure we've done it that well in some units around the place in the UK. I'm in a moment going to hand over to my colleagues Hassan and Tommy, if that's okay. But I just wanted to ask you, you're a little bit further on, I guess, from the UK, and I think one of the big concerns is that because all of the units, if you like, have been completely focused on COVID, and I think Christoph Lees also kind of just touched on this in his talk, kind of what's happened in Italy, because there's been a lot of concern that maybe people are missing antenatal appointments, maybe there'll be more stillbirths, and also late diagnosis of cancer, and emergency departments saying that they're just not seeing people coming in with heart attacks and so on. So kind of what's happened in Italy? Have you in your department suddenly seen a huge number of people with postmenopausal bleeds and ovarian cysts who are sitting at home? I mean, what's happening?
No. I mean, for the maternal fetal medicine, we had no change. All the patients were coming, and we were very keen on keeping very long appointment distance between patients. So there were only 1 patient in the waiting room. No accompanying person was allowed to enter the waiting room. We decided to allow the partner to be present in the labor room, while many units in Italy and even in my region didn't allow that. I thought that it was not right. So we allowed the husband or the companion to come in the labor ward, but they had to wear the surgical masks. As far for the gynecological problems, we had problems because we only gave, well, we could be able to give, to make the oncological patient to have the treatment and to have the surgery. But other cases, we only took the very urgent case of surgery. So nowadays, when we started again to do the normal clinical practice, we have a long list of patients who have to be introduced in the clinic, because we stop everything for 2 months.
You're in the same position as us then, really. We're going to have a big backlog.
Yeah.
Okay. Tiziana, what I'm going to do is hand over at this point to my colleagues, Hassan and Tommy, who are going to take over. They have got an enormous number of questions. I think they're all directed towards Beverly, so that's great. Good luck with those. and so maybe if you'd like to have a small glass of espresso or something, and we'll hand you over. Over to you, guys.
Okay, thank you very much, Professor Bourne. And thank you very much for all the speakers for the excellent presentation. It's not up to me to say. But if you will allow me, I'll start. We have plenty of questions, as Professor Bourne has said, and we'll try to cover as much as we can. But of course, for the interest of time, we're not going to stay for a very long time. Now, most of the questions are for Professor Hunt, as Professor Bonner said. And let me start with some of them. Can low-dose aspirin? Can we use aspirin for thromboprophylaxis? And can what is the role of corticosteroids? Is there a role for thrombolytic drugs in severe COVID infections? And also, what about anti-inflammatory drugs, and which one of them is better for cases of acute COVID?
So, using aspirin, I would use aspirin where I normally use aspirin. In pregnancy, I use it in my antiphospholipid patients and those with high risk of preeclampsia. There is no evidence to support the use of aspirin in severe COVID. There will be an arm on REMAP-CAP, which is the trial looking at patients who are critically ill. And that's a question that everyone wants to know the answer to. Will an antiplatelet agent might make much difference? I would think probably not much, but we need to look at it at a later stage. Antifibrinolytics, they are dangerous if you use them in an uncontrolled way. We would normally, if somebody had intermediate risk or high risk pulmonary embolism, and they were pregnant and they had COVID, we would try to give them thrombolytics as we would in somebody who didn't have COVID. But again, we'd be very careful. We always use catheter-directed thrombolysis in that group because of the high risk of bleeding. We don't really want systematic fibrinolysis. When to use an anti-inflammatory drug? Well, at the moment, we don't know that any anti-inflammatory drug has got any effect. So I would try and enter a patient into a trial using an anti-inflammatory. And really, it's a question that David ought to answer.
Okay, maybe
David
Williams.
Nicely passed. that's my word. You should have been playing in the centre for Wales in 1980 or something for that one.
You can unmute your microphone, Dr.
You can
Williams.
unmute David.
So what are you going to do, David?
Yeah, there we go. I should have stayed on mute. Of course, the anti-inflammatories are promising because in the end, this is an inflammatory condition, and then the thromboembolism, thrombotic events are secondary. But we lack, number one, the clear indicators as to who's going to progress and benefit, therefore, from early onset anti-inflammatory treatment. And I'm sort of rather cynical that we're actually going to get there with this, and that prevention will always remain the best option. You know, I think once you're on a ventilator, and then when you've been on a ventilator for a week, it's bleak. You know, you don't do well. It's less than 20% get off the ventilator at that point. 80% die. Would they do better with an anti-inflammatory? I'm not sure. I think it's too late. There's a lot of mechanical damage as much as thrombotic damage. It becomes irreparable.
Right, thank you. Any role for oral anticoagulants before I pass the next question to Dr. Musa?
So oral anticoagulants in pregnant women, no, that's easy. Yeah. Because we know warfarin crosses the placenta and the direct oral anticoagulants cross the placenta too. So we don't want to use oral anticoagulants, that's easy. If a woman is leaving hospital and requires extended thromboprophylaxis after delivery, and they're not breastfeeding, you could consider using a low dose of one of the DOACs, but it's off license really in that period of time. Low molecular weight heparin is so tried and tested, isn't it? And most pregnant women have got used to taking it. So it's the #1 choice. And when I have a patient with a high risk of bleeding, I always use low molecular weight heparin as the anticoagulant of choice. It's got the minimal bleed risk compared with the others. Is that okay?
Yeah.
Okay.
A question to Christoph. Christoph, are you here? Christoph? No, he's not around. Oh, here he's here.
Yeah, sorry. Yes, I am.
Yeah. We got a couple of questions for you. The first one, how to reduce vertical transmissions. I know you didn't talk about that. Is there a role for vertical transmissions that happening in COVID cases, and your data from your hospital? And the second one is related to Cat 1 cesarean section. Somebody will need a very quick delivery, suspected, may be at a risk of COVID or suspected or confirmed. What shall you do in these cases?
Yeah. So the first question, vertical transmission. In fact, this is very, very problematic because you can't actually easily at the moment determine what is true vertical transmission. So is it vertical transmission, or is it transmission in the first few minutes or hours the baby is born, or is it something does the baby get it environmentally? So no one has good data on vertical transmission yet. But what we do know is that babies born to women who are COVID positive, the risk is somewhere between 0 and 10 probably of transmission, and most studies are coming up with about 3 or 4%. I think that's what Tiziana Frisco showed as well, roughly that. So we're talking about the low percentages. Low single digit percentages. And we don't regard that in many centres in the UK as a sufficient reason to separate mother and baby. So that's #1 question. I suspect most European countries are very similar in that. The #2 question about a category 1 cesarean section. Well, I think there are 2 things there. One is screening women when they're in labour or when they come in labour, because there are point of care tests now available that are being used in the UK and elsewhere that will give you an answer within an hour or 2. They're little black boxes. You take a swab when someone comes in labour, and then you know if you need to do an emergency section, you're sort of ready for it. You've got all the PPE ready. And once you've got all the PPE ready, it takes it does take an extra few minutes. And I would say it takes an extra 5 or 10 minutes if you've got everything ready to do a category 1 cesarean section. And we've been in that situation.
Christoph, is that DNA nudge?
That is DNA nudge, yes. The DNA nudge that is being used in the UK and has MHRA exemption at the moment to be used in healthcare facilities. So that's an Imperial College test, but there are tests. I know King's have a test and Southampton have a test as well. So they're all sorts of rapid point of care tests. And so I would say that if you've triaged someone, you should have PPE ready, and we're much better at putting PPE on now than we were. The real issue is with the anaesthetists, because a category 1 cesarean, of course, they will want to do a spinal anaesthetic, which is fine for most category 1 cesareans. But if they end up needing to do a general anaesthetic, it does mean that everyone in the theatre has to use full PPE and FFP3 masks, the whole stuff. So that the real issue here is a general anaesthetic that does slow everything down hugely. But in general, in my experience, and I've done cesareans in several women who either suspected or confirmed, we haven't actually had an issue because we've predicted what we might need to do an hour or 2 in advance. It would be interesting to know whether Tiziana agrees with me or not on that.
Can I say goodbye? I'm really sorry. I've got another
lovely.
call.
Okay.
Is that okay?
Lovely.
Sorry, Tom.
Yeah, lovely to have.
Sorry.
Thanks very much.
Thank you very much, Professor Hunt. Thank you very much. And
Sorry.
we hope we'll have another meeting in a physical meeting in Egypt in one of our conferences once this corona madness is.
When life is beautiful again.
Yeah.
Bye.
Bye.
As far as our experience in Italy, we now perform the swabs to all patients who are coming in labor or coming for surgery. We did start to perform elective normal surgery, not oncological patients only. But as we don't have the response of the swab in 1 hour, as Chris is saying, we need more time. Maybe because there are organizing problems, we need 4 or 5 hours to have the response. So we divide the patient in the green patient when they are negative, red patient where they're positive, and gray patient where we don't know what they are, how they are from the COVID patient, from the COVID problem. And in this patient, if they are in labor, we will use the same protective device as FP2 and coverage and face shield. And in case they need a cesarean section, we'll treat them as COVID positive.
Okay, that's a very good answer, because there was a question about whether a cesarean section would be more infective than a vaginal delivery would be more infective. Then there are questions about the transmission of the virus through stools and through semen. And then also there are questions about the use of convalescent plasma and any indication of early delivery. So which ones of these questions would you like to take? Any indications to deliver the lady earlier
yeah.
Sorry.
Well, I was just going to comment on that I've had several experiences now where obstetricians have been very keen to deliver early a pregnant mother before 30 weeks with a rather nasty looking chest x-ray, but where the clinical parameters, oxygen saturations in particular, didn't quite stack up. So didn't really necessitate early delivery. And you know, pregnant women can recover from COVID. They're young and generally fit, and the pregnancy can continue. So I think only when they're really in extremis and you're thinking about ventilating them, would the delivery by cesarean section be an option. So unlike H1N1, which was a different experience.
David, can I just ask you a question in relation to prematurity?
Yeah.
Come up a couple of times in the question, which is the issue about giving dexamethasone and its safety.
Yeah.
And that's obviously a very important question just to deal with and answer. Would you mind dealing with that?
Yeah, it's a good question, and it should be given if there's time to give it, and hopefully there would be. It's absolutely needed for those who would be getting it anyway. You know, if you want to go before 34 weeks, whatever it is. Yeah, so don't hold it back because of COVID.
David, very quick question about antiviral. You mentioned it is currently showing a significant effect in advanced cases. Should we consider it at earlier stage?
I don't think so. I mean, the data from the New England Journal paper just a few days ago is there's no control, you know, and they were men and non-pregnant women. So where I'd have no hesitation in giving it if I thought it was going to be of benefit, I still think that the benefit is a little unclear. What we do know from the actual drug company that makes remdesivir, Gilead Sciences, they showed that I think there was a 3-day shortening in the recovery period in those that received it. So maybe someone who's heading to ventilation should receive it.
Okay, another question, is laparoscopy considered aerosol producing procedure? And related to this, how often should we change our surgical mask during a day on call? Also, should we change our PPF FFP3 between cases in theater? And finally, is two regular masks, are they equivalent to one N95?
Okay, I've actually, Hassan, I've answered these questions already, so I've answered them in the chat. So hopefully those that have asked the questions will get the answers. But generally speaking, a mask, a mask, as long as it's not wet or damaged or got splashes on it, will last about 3 or 4 hours. That's what most people say. So that's a session, a morning or an afternoon session. FFP3 masks, we tend to change between tend to change between cases if we're doing laparotomies such as cesarean sections. Having said that, it's rare that we will be dealing with suspected or probable COVID-19 and then another suspected or probable COVID-19, because we're doing point of care tests. We know which cases are positive and which aren't in the main that go to theatre. But yeah, mask about 3 or 4 hours or so. There is no rationale for using 2 surgical masks, one over the other. It'll just make you breathe very hard, and you'll probably get oxygen and keel over and need to be resuscitated. So I would not recommend that at all. And the other thing is sorry, let me just show you this. This mask has gaps either side. So while it protects against direct droplets and splashes, it doesn't protect against anything going in from the sides, which is where's my FFP3 mask? I've lost it. It's gone. But my FFP3 mask fitted very snugly on the face, and that we're fit tested to check that our face is the right shape to take the mask and that there aren't big gaps. And that will protect against aerosols and droplets. So no, however many surgical masks you choose to place on your face at once will not reduce the risk of getting coronavirus. You must use the proper mask for the proper indication.
Right, thank you very much. There is Professor Dr. Wafa Benjamin is going to ask the final question because we are running out of time. Dr. Wafa.
Yes, it's one last question for Dr. Williams as well. The use of plasma from recovering patients. It's gaining much popularity in Egypt. What is the evidence of its use till now?
Convalescent plasma.
Convalescent plasma. So
yes,
people who have had and recovered from COVID-19, and then 28 days later, they give their plasma through a process that takes about an hour actually to get the blood off. And there's been a small little case series in China where critically ill patients with COVID-19 recovered, but it was not randomized. So that's what we're getting, a small case series and cases that are coming through. 1 or 2 disappointing ones as well, so it's not all positive. The NHS blood and transfusion service are really promoting this in this country, and I hope will report in the next weeks about their experience. But at the moment, it's a good idea, and it has worked, but it's not of proven efficacy.
Thank you, Dr. Williams. I think we have plenty of questions, but of course, for the sake of time, we will not be able to answer everything. Maybe we can answer back to you by email or something. I want to thank everybody, all the international speakers for their world-class presentations as expected. And I will pass the final word to Professor Bourne to conclude the webinar.
Well, thank you. Well, first of all, I'm sure on behalf of all the speakers, Hassan and Tommy, thanks very much for inviting all of us to take part in this. I think it's been a fantastic webinar. It's covered a lot of the really big issues I hope that people face from a practical point of view. I think everybody worries how they're going to manage their department, and Tiziana covered that very well. Christoph, a very practical practically covering what you need to use for PPE and some of the evidence, and then David and Beverly talking more about some of the therapeutic things. I mean, I think the clear thing about COVID is, I think, was it Churchill? You know, it might be the beginning of the end. It's not the beginning of the end. It's the end of the beginning, I think, is the quote. But and I have a funny feeling that's where we are with COVID. I think both in terms of what happens to some of these patients over the course of time, about the indirect consequences which we touched on with patients who haven't been coming into hospital, which is going to be a problem. And of course, we all worry that there's going to be a second wave. So I think even though some countries, the numbers are going down, it's prudent to be prepared. When it comes to therapeutics, David, I think you probably agree. I think you know, we are waiting trials and waiting the hopefully interventions at the level which Beverly talked about, perhaps with anti-inflammatories and so forth, or trying to deal with the cytokine storm. But we're quite a long way off any of that really at the moment, and we're quite a long way off getting a vaccine. So I think a lot of this comes down to protecting yourself very carefully, using PPE, trying to get testing and tracing and all these things and public health measures right, I think, for the moment. I suppose the one good thing is, I think, that we haven't had the situation with pregnant women that we had with previous infections, and it does at least seem that in general terms, they're not affected as badly as perhaps they were with earlier coronaviruses. So I suppose that is the little ray of sunshine. So I'd like to thank all of you in the audience. Thank you very much. Thank you all of the speakers who, one or two looking a bit hungry if they haven't had any dinner yet, I'm not sure. Maybe you eat a bit later in Egypt, but as you go further north in the world, as you well know, we tend to eat earlier. You get to Scandinavia and you have your dinner at about 5 o'clock in the evening, because I remember doing that when I worked in Sweden. I don't know if Hassan or Tommy want to say anything, but I think I'll just close there. And everyone who's listening, be careful, look after yourselves, and perhaps see you next time, hopefully at a meeting in Egypt when we can meet you all in person and go out and have a wonderful dinner and enjoy hospitality and be sociable. So I look forward to that.
Hopefully so, and thank you very much for the board, and thank you for everybody, and thanks for Tommy Musa, because he was the brain behind all this gathering, and à la prochaine, as we say in the in French, in our part of the world. Thank you very much, everybody, and until the next meeting. Thank you, Wafa, for all your help. Good night. And thank you for the audience, of course. بس يا دكتورة شدوى ولا ديان؟
ميرسي بروفيسور حسن.
كتر خيرك.
ميرسي لحضراتكم.
دكتور موسى، دكتور حاتم، how do you think it went؟ ولا احنا لسه الناس معانا في
احنا لسه الاتنديز معانا.
طيب ماشي، نشكرهم جميعا طبعا. Thank you very much. I know they come from every part of the world. احنا كان عندنا ناس, we had people from India, from Nepal, from Peru, from Paraguay, from Mexico, from North America, from most European countries, and Turkey, and many other places. Really, and I think Dar es Salaam, it doesn't, I don't know if it's Dar es Salaam, Tanzania, or Dar es Salaam, Brunei, Dar es Salaam. But thank you all, and we hope you will join us in some of our future webinars or scientific activities. In fact, we have many other activities. We have training courses. Some of them are run by Dr. Musa, Dr. Tommy Musa. As you know, he's an expert in ultrasound in obstetrics and gynecology, and he runs this course for us once or twice a year. I don't know if I hope we'll be able to do it again shortly. We also have laparoscopy courses, hands-on laparoscopy courses, suturing courses, intermediate laparoscopy, hysteroscopy, and all these are hands-on workshops. We have an infertility workshops, and you can add to what I'm saying, Dr. Wafa. Wafa, can you hear me?
Yeah, yes.
Huh?
Yes,
and
yes, I can hear you.
You're the organizer of all these scientific activities. Okay. What other courses we have? Pelvic
yes,
floor.
very soon we will have one for obstetric emergency.
Obstetric emergency.
Especially in COVID-19. Yes, in COVID-19, which is we did before with the anesthetist, obstetric anesthetist, and it's a very good quality to attend. It will be on the 2nd of July.
On the 2nd of
It
July.
will be on online course on 2nd of July. Yes.
Okay. Having said this, I want to thank you all very much, and thank you, Dr. Musa, for everything, and thank you, Mina Farm, for all your help and all your support for our activities.
Thank you, Professor Hassan. It was our pleasure.
Thank you very much, Dr. Shah.
I think it's really important to get feedback as well from people who participated. Yes. You could see on the side the feedback. Large people are writing from different parts, so it would be really nice if we managed to get that feedback.
Perfect webinar. This is Marie Shokralla. I don't know where she is from. A very rewarding practical meeting. Hazem Abdul Ghaffar from Nihal Nabil. Hope you recorded the lecture to share it on the Facebook page. Ayman Abul Ala, perfect meeting. Thank you all for your excellent organization. Sahra Abdul Daim Abdul Adel, many thanks for your webinar. Michelle Aziz, my thanks as well. Anna Abu Raya, professor of rheumatology in Alexandria. Excellent webinar, Professor Hassan, Dr. Anna, and Dr. Susan Abu Raya, the heads of the rheumatology department and the head of the internal medicine department. Thank you for being with us. And very useful meeting, Dr. Muhammad, Nijar Mullah. Thank you very much for the excellent talk, Dr. Nijar, who is an obstetrician. Great webinar. Thank you, Dr. Sharif Fathi, Amal Kamal. Thanks a lot. From Wisal Agra. Thank you a lot for a very comprehensive meeting. Well, we're really very humbled, and we want to thank you for participating, and hope we will be together again. From Professor Sameh Zaki, the chair of Obstetrics and Gynecology in Cairo University. Thank you very much, Professor Hatem, fantastic webinar. Thank you, Professor Sameh Zaki, for taking from your time and joining us. We are really very elated and humbled. Rosalia Mahmoud Mohammed, excellent, very interesting presentation. Tara El Arabi, always proud. Thank you very much. Plenty of, I hope more meetings and a follow-up. Amal El Fawwal, Samar Saeed Abdo, many thanks. Dr. Shamshad Azim, he could be from Pakistan. I know there is somebody from Pakistan, 2 people from Pakistan with us. Informative, very informative webinar. Thank you very, very much. And with this, we come to the end of this webinar, and we leave you to have a nice dinner and a good sleep. Thank you very much. Good night.